Good morning. We're going to get started this morning, and thank you all for being here. Nearly 60 million individuals in the United States rely on Medicare for their health care, and in my home state of Kansas alone, almost 1 in 5 Kansans depend on the Medicare program. As one of the government's largest and most complex programs, Medicare is highly susceptible to fraud, waste, and abuse. And because of this, Medicare has been designated as a high-risk program for almost 3 decades. In 2017 alone, improper payments accounted for nearly $52 billion of Medicare spending. Fraud in particular is often challenging to identify and measure due to its deceptive nature. Fraud may also be non-financial, making it even more difficult to measure. The Centers for Medicare and Medicaid Services, or CMS, measures improper payments, some of which may result from fraud. However, while CMS identifies improper payments through the Comprehensive Error Rate Testing, or CERT program, it is difficult to get a clear understanding of which improper payments are a result of fraud and which are simply a mistake. So how much fraud is in the Medicare program? Right now, there are varying opinions about the bottom line and what is too much. Currently, Medicare anti-fraud efforts focus on identifying fraud after it has occurred in a pay and chase format. Instead, CMS should focus on identifying and assessing where there is fraud, risk of fraud, before it happens, which I understand CMS is starting to do. Fraud risk exists when there is the incentive, opportunity, or pressure to commit fraud. By focusing on and mitigating fraud risk in Medicare, CMS can reduce the likelihood and impact of fraud in the program, preventing it before it occurs. The Government Accountability Office, or GAO, developed the fraud risk framework in 2015 in order to guide agencies' efforts to combat fraud. Congress liked the framework so much that we passed the Fraud Reduction and Data Analytics Act of 2015, requiring federal agencies to incorporating leading practices from the fraud risk framework. As it stands now, there is no comprehensive risk-based strategy for combating fraud in Medicare, and CMS has not conducted an assessment of Medicare using the framework that would allow it to develop such a strategy. Without a strategy in place, it is very difficult to address fraud. Today's hearing will cover ways in which CMS can continue to improve its anti-fraud efforts, including the development of a comprehensive anti-fraud strategy. The witness panel will provide helpful updates on CMS's current anti-fraud efforts and where there is room for improvement. Our goal here today is to better understand what needs to be done to more effectively combat fraud in Medicare and to support those efforts however we can. Unfortunately, at CMS, there seems to be some level of acceptance of the improper payment amount. However, I know this is something every member of this subcommittee wants to improve, particularly given that every dollar lost to fraud is a dollar that could be spent on patients. I want to thank our witnesses for being here today, and I look forward to their testimony. And now I would like to yield to the distinguished ranking member, Mr. Lewis, for the purpose of an opening statement.
Well, thank you, Madam Chair, for holding this hearing. I apologize for being a little late. You know, these elevators move slowly, and I was trying to move faster, but I'm delighted to be here. Thank you, Madam Chair, again. Thank you for holding this hearing. And thank you to our witnesses for taking time to be with us today. You're a good-looking group, and I look forward to hearing words from you. Madam Chair, this subcommittee's work touches many areas, but protecting and preserving Medicare is perhaps our most sacred obligation. The fight against fraud, waste, and abuse is not a partisan matter. Medicare covers 58 million elderly and disabled beneficiaries from every state, from every section, from every corner of our great country. This subcommittee has a long and historic track record of bipartisan work, preserving the sacred trust of our seniors, families in need, and people with disabilities. I deeply believe that the fight against fraud, waste, and abuse is essential to keep the premise of Medicare for all who rely on it. Yet, as we recommit to fighting fraud, let us take care. Our first priority should be to ensure that beneficiaries have access to quality and life-saving services. As Medicare adopts new payment models, this administration must continue President Obama's work to fight new forms of fraud. They must continue the Affordable Care Act's investments and innovation in preventing fraud before it happens. Madam Chair, I will always welcome the opportunity to work with you to strengthen and protect Medicare, just as I did almost 1 year ago today when this committee held the exact same hearing with essentially the exact same agency at the witness table this morning. Little time remains in this Congress, and each day the news continues, troubling reports about the state of our health systems. For the past 18 months, the Committee on Ways and Means has made little mention about patient access to care, social determinants of health, the closure of rural hospitals, or the price of prescription drugs. I hope that we can find more areas in which to work and continue our committee's bipartisan commitment to Medicare beneficiaries. Thank you, and Madam Chair, with that, I yield back.
Thank you, Mr. Lewis. Without objection, other members' opening statements will be made part of the record. Today's witness panel includes 3 experts. Cito Bagdoyan, Director of Forensic Audits and Investigative Service at the Government Accountability Office. Gloria Jarman, Deputy Inspector General for Audit Services of the Department of Health and Human Services Office of the Inspector General. Alec Alexander, Director of the Center for Program Integrity at the Centers for Medicare and Medicaid Services. The subcommittees received your written statements, and they will all be made part of the formal hearing record. You will each have 5 minutes to deliver oral remarks. And so we will get started. We'll begin with Mr. Bagdoyan. You may begin when you're ready.
Thank you, Madam Chairman. Chairman Jenkins, Ranking Member Lewis, and members of the subcommittee, I'm pleased to appear before you this morning to discuss GAO's December 2017 report on how CMS manages fraud risk in its programs, including Medicare. In 2017, Medicare expenditures totaled $702 billion, or about 18% of all federal outlays, covering over 58 million beneficiaries. Reflecting an aging population and rising per capita health care costs, CBO projects these expenditures to rise to about $1.5 trillion by 2028, or the equivalent of about 21% of all federal outlays. This is an annual average growth rate of 7%. The current and projected levels of spending for Medicare highlight what's at risk from potential fraud and why it's imperative for CMS to comprehensively address would-be fraud risks to the program. Illustrating the magnitude and reach of potential risks, recently the Attorney General and HHS Secretary announced a major healthcare enforcement action involving 601 defendants across 58 federal districts, including 165 doctors, nurses, and other licensed medical professionals for their alleged participation in healthcare fraud schemes totaling more than $2 billion in false billings for, among other things, medically unnecessary treatments and prescription drugs. Relating to Medicare, 124 defendants were charged with offenses relating to various fraud schemes totaling over $337 million in false billings for services such as pharmacy fraud. With this in mind, I'll now focus on 4 central points from the December 2017 report. First, consistent with GAO's fraud risk framework, CMS has demonstrated commitment to combating fraud by creating a dedicated entity, the Center for Program Integrity, to lead overall anti-fraud efforts with direct reporting line to executive-level CMS management. Second, CMS has taken steps to establish a culture conducive to fraud risk management, although it could expand its anti-fraud training to include all employees. Consistent with the framework, CMS has promoted an anti-fraud culture by, for example, coordinating with internal stakeholders to incorporate anti-fraud features into new program design. To increase awareness of fraud risks in Medicare, CMS requires training for stakeholder groups such as providers, but does not require the same training for most of its own workforce. The framework identifies training as one way of demonstrating an agency's commitment to combating fraud. Training and education intended to increase fraud awareness among employees serves as a key preventative measure to help create an agency culture of integrity. Third, CMS has taken some steps to identify fraud risks in Medicare. For example, it has identified fraud risks through control activities that target areas the agency has designated as higher risk, such as home health care providers. However, CMS has not conducted a fraud risk assessment for Medicare as a whole or developed a risk-based anti-fraud strategy. 4, CMS has established monitoring and evaluation mechanisms for its program integrity activities that, if aligned with anti-fraud strategy, could enhance the effectiveness of fraud risk management in Medicare. CMS uses a metric called return on investment and savings estimates to measure the effectiveness of its program integrity activities. In developing an anti-fraud strategy, CMS could include plans for refining and building on existing methods, such as the ROI measure, to evaluate the effectiveness of all of its anti-fraud efforts. In closing, I'd underscore that as CMS has already agreed with the 3 recommendations in our report, it's essential for the agency to place a high priority on implementing them in a timely fashion to help better manage fraud risks in Medicare. Doing so would provide reasonable assurance that the program's expenditures, totaling hundreds of billions of dollars annually, will be adequately safeguarded. Otherwise, dollars lost to fraud could significantly detract from CMS's ability to ensure that individuals who rely on Medicare are provided adequate care. Chairman Jenkins, Ranking Member Lewis, this concludes my remarks. I look forward to the subcommittee's questions.
Thank you, Ms. Jarman. You are recognized.
Good morning, Chairman Jenkins, Ranking Member Lewis, and distinguished members of the subcommittee. I am Gloria Jarman, Deputy Inspector General for Audit, Office of Inspector General, Department of Health and Human Services. I appreciate the opportunity to appear before you today to discuss OIG's strategy to combat fraud and promote program integrity in Medicare. Medicare represented more than 15% of all federal spending in 2017. Expenditures can be expected to rise further as the number of beneficiaries increases and the per capita health care costs continue to increase. This makes it more important than ever to protect Medicare's financial integrity by fighting fraud and reducing improper payments, a central component of OIG's mission. OIG's multidisciplinary team conducts audits, evaluations, and investigations that identify improper payments, assess internal controls and payment vulnerabilities, and build cases against those who seek to defraud the Medicare program. This work has led to numerous fraud convictions and has generated recommendations for improper payment recovery and prevention of future improper payments. OIG has long been in the forefront of measuring, monitoring, and recommending actions to prevent improper payments. We developed the first Medicare payment error rate in 1996, at a time when there were few error rate models in government. In this context, it is important to stress that while all monetary losses from fraud constitute improper payments, not all improper payments are fraud. A comprehensive program integrity strategy helps to address multiple sources of improper payments, including fraud. Today, I would first like to highlight OIG's 3-pronged approach The focus is on prevention, detection, and enforcement. CMS's Fraud Prevention System, or FPS, serves as an important tool for preventing fraud and other types of improper payments. However, OIG recommends improvements to the FPS that would increase its effectiveness. Specifically, we have recommended that CMS ensure that its redesigned FPS can track savings from administrative actions back to individual FPS models. We have also recommended that contractors report only FPS-related savings amounts to CMS. Finally, we have recommended that evaluations of FPS model performance consider not only identified savings, but also the amount that is likely to be recovered. To help increase the effectiveness of our fraud detection efforts, OIG uses advanced data analytics to scrutinize millions of claims and billions of data points. Once suspected fraud is detected, we thoroughly investigate the facts and aggressively enforce the law when warranted. OIG partners with the Department of Justice and HHS on Medicare strike force teams and other healthcare fraud enforcement activities through the Healthcare Fraud and Abuse Control, or HCFAC program. Just last month, OIG, along with our state and federal law enforcement partners, participated in an unprecedented nationwide healthcare fraud takedown. The takedown represented the largest multi-agency enforcement operation in history, both in terms of the number of defendants charged and total loss amount. I would also like to speak today about OIG's use of risk management practices to improve decision-making. We integrate these practices into all aspects of our work. The risk assessment process for our audit work considers a variety of factors, including fraud-related risk factors that are based on GAO's framework for managing fraud risks in federal programs. The information we obtain from ongoing risk assessments helps us prioritize our work and guides the development of our work plan. While OIG historically published an annual work plan, we now maintain a dynamic work plan that's updated throughout the year to keep the public better informed. Each year, we also identify the top management and performance challenges facing HHS. While these challenges cover a wide range of critical departmental responsibilities, ensuring program integrity in Medicare remains a top management challenge for HHS. Thank you again for the opportunity to testify this morning, and I'm happy to answer any questions you may have.
Thank you, Mr. Alexander. You are recognized.
Good morning, Chairman Jenkins, Ranking Member Lewis, and members of the subcommittee. Thank you for the invitation and the opportunity to discuss CMS's ongoing efforts to protect taxpayer dollars by protecting the integrity of the Medicare program. CMS takes very seriously our responsibility to make sure that we're paying the right amount to the right party for the right beneficiary in accordance with all applicable laws and regulations. As a former Assistant United States Attorney who was responsible for prosecuting healthcare fraud, I've seen firsthand how Medicare fraud can inflict real harm on beneficiaries. When fraudulent providers perform medically unnecessary tests, treatments, procedures, or surgeries, or prescribe dangerous drugs without thorough examinations or medical necessity, program beneficiaries are put at risk. When fraudulent providers steal a beneficiary's identity and bill for services or goods never rendered, that beneficiary may later have difficulty accessing care. Strengthening our program integrity efforts protects beneficiaries from harm that fraudulent providers and bad actors might otherwise cause, and at the same time it safeguards trust fund dollars. While we're not a law enforcement agency, we do collaborate closely and on a regular basis with our law enforcement partners. Most recently, CMS began and is leading an important new process improvement we call major case coordination. This innovative initiative provides an opportunity for CMS policy experts, law enforcement, including HHS OIG, the Department of Justice, the Healthcare Fraud Strike Force, as well as CMS fraud investigators to collaborate before, during, and after the development of fraud leads. This involves weekly meetings to discuss and prioritize new leads and coordinate and assign appropriate paths for resolution. This early and frequent collaboration and coordination maximizes our joint ability to identify, investigate, and pursue fraudsters who might otherwise endanger program beneficiaries or steal from federal programs. Just last month, As was mentioned, HHS, along with the Department of Justice, OIG, and other law enforcement partners, announced the largest ever healthcare fraud enforcement action by the Medicare Fraud Strike Force. More than 600 defendants were charged participating in fraud schemes involving approximately $2 billion in losses to Medicare and Medicaid. Only 45 days after being referred to the strike force as part of this new coordination effort that I've described, one of those reviewed cases was charged as part of the June 28th healthcare fraud takedown. CMS has been working to identify and prevent fraud for decades, and we truly appreciate the extensive work of the GAO to provide a systemic conceptual framework within which we can assess areas at risk of fraud across our programs. CMS is also strengthening our efforts to ingrain fraud risk assessment principles throughout the agency to cultivate a culture of program integrity and to ensure that this critical work does not occur in a silo. We will continue to work closely with GAO and other stakeholders as we take steps to expand our capacity to conduct fraud risk assessments and make the process more standardized and more efficient. CMS is also using a number of other tools to identify and prevent fraud, waste, and abuse in our programs. As was mentioned, the fraud prevention system allows us to implement prepayment edits and stop payments before they go out the door. Through advanced data analytics and modeling, it also allows us to better target investigative resources toward suspect claims and providers and swiftly impose either administrative action or make law enforcement referrals when they're warranted. Additionally, when one of the fraud prevention system's approximately 100 predictive models identifies egregious suspect or aberrant activity, the system automatically generates leads for further review and investigation. The FPS helped CMS identify or prevent $527 million in inappropriate payments during fiscal year 2016. This reflects a return on investment of $6.30 for every dollar spent on that effort. Recent work of the OIG is helping us in our efforts to continually improve the fraud prevention system. In addition to our efforts to identify and prevent fraud, waste, and abuse, we're also taking a number of steps to lower the improper payment rate across our programs. It's important to remember that while all payments resulting from fraud are improper, most improper payments are not fraud. Under the leadership of Administrator Verma, CMS is re-examining existing corrective actions and exploring new and innovative approaches to reducing improper payments while minimizing burden. And because of the actions we have put into place, we're glad to point out that the Medicare fee-for-service improper payment rate fell from 11% in 2016 to 9.5% in 2017, which represents about a $5 billion decrease in estimated improper payments. And going forward, we must continue our effort to identify vulnerabilities in the program and in our payment systems and develop mitigation strategies to proactively help reduce fraud, waste, and abuse. CMS shares the subcommittee's commitment to protecting the safety and health of beneficiaries and to safeguarding taxpayer and trust fund dollars and to strengthening the Medicare program to ensure its long-term sustainability for the millions of beneficiaries we're honored to serve. We thank you for your interest in our work, and I look forward to any questions you may have.
Thank you for your testimony, each and every one of you. We'll now proceed to the question and answer session, and I'd like to direct my first question to Mr. Begdoyan. Can you expand on the purpose, of a risk-based anti-fraud strategy? What are the benefits of being able to assess and mitigate the risk of fraud?
Thank you for your question, Madam Chairman. A strategy is basically a roadmap that allows an agency, in this case CMS, to meet its mission. It has objectives within that mission, and it has a capacity. There is an asymmetry usually between the two, and an anti-fraud strategy is designed to close the gap in terms of meeting the mission while also achieving fraud management. Now, a strategy is the best way to organize and target the disparate measures that CMS and CPI have in place already, plus any new ones that might be needed to target those against prioritized risks. You certainly cannot address each and every risk, so you have to prioritize them, and a strategy provides the best roadmap to do so.
Okay, what would an effective anti-fraud strategy look like? And can you talk a little bit about what other agencies or entities that have successfully conducted a fraud risk assessment using the fraud risk framework and how that has informed a risk-based anti-fraud strategy?
Sure. Just to follow up, a strategy is basically the result of performing a risk assessment in which you identify all the risks that are facing a particular program. Then you create a risk profile, which is essentially the documentation from the assessment. And there could be various assessments, certainly. And the profile identifies in priority order what the risks that need to be addressed. And then the strategy comes in with identifying the existing controls that are in place, and also identifies any new ones that are needed, any new controls, how they might be sequenced in a particular program, how they work with each other, and essentially also has performance measures to see whether any of these activities actually move the needle, so to speak, in terms of achieving a reduction in fraud or better management of fraud. And in terms of your other subpart to your question, the framework has been around for about 3 years now, and we have applied it to various agencies. And to be candid, most of them are still struggling to come up to speed in terms of fully utilizing the capabilities that are within the framework. So there is a lot of good faith effort. We have seen, as I described, within CMS, they have lots to build on. It just needs to be better organized and focused and targeted.
Thank you. Mr. Alexander, CMS has a number of anti-fraud initiatives in place. Can you describe CMS's efforts to align its anti-fraud initiatives with GAO's framework, the fraud risk framework? If you'll turn your mic on. Thank you.
Thank you, Madam Chairman. Of course, we're grateful to have the GAO guidance with respect to the fraud risk framework, and we use it and are using it every day. We assess fraud risk in all of our programs every day. This is a continuous effort because fraud and fraud risk evolves day to day. We are also standing up right now, which is and will be integrally associated with our use of the framework, a vulnerability management process that we're at the end of putting into place, which will do and incorporate essentially all of the elements of the fraud risk framework that the GAO has outlined. Specifically, this is enterprise-wide look across the horizon at emerging fraud risks. Bring them together with the entire team, prioritize them, analyze them, score them for likelihood of occurrence and impact if they do occur, attach action plans to them to ensure, as my colleague indicated, that we move the needle from red to green, and then attach an outcomes assessment tool at the back. We do that not only at payment system level on a regular basis, not only with respect to, for example, the marketplace and the exchanges, we've done it, we're doing it in modeling from CMMI, but we do it at the program level, and more particularly and more granularly, we do it at the issue level. So when each of these vulnerabilities are identified, we put it into this vulnerability management process. We will be doing a version of exactly what's recommended in each of those. Now, the GAO report was also very thoughtful in observing that because of the size of our program, probably makes sense not to try to eat the elephant all at once, but instead to break it into some sub-assessments, which is essentially what we're trying to do. But I want the committee to be aware and GAO to be aware that we are following exactly those protocols. And in fact, they mirror pretty standard enterprise risk management practices that were described a moment ago.
Okay, thank you. And finally, Ms. Jarman, what role does the Inspector General have in managing fraud risk in Medicare?
We have a significant role in managing fraud risk in Medicare as part of our oversight role in the OIG, and due to the large size of the Medicare program, like I think it was mentioned, it was almost about $700 billion. So we're continually overseeing how the department is managing Medicare, and even in determining what work we do, whether we're doing audits, evaluations, or investigations, we have to do our own risk assessment to determine what areas to focus on. And we have what we call priority outcomes because of the size of the programs that we're responsible for. And that continues to evolve. We determine what areas we're focusing on. Like in the Medicare, the improper payments have been higher in the non-institutional settings, like home health agencies. And so we have additional focus on Medicare work in looking at claims in those areas. And we're continuing to do advanced data analytics to look at areas that we should focus on. So we use our own risk assessment in deciding what work we do and in overseeing the department.
Okay, thank you. Now I will recognize Ms. Del Bene for 5 minutes.
Thank you, Madam Chair, and thanks to all of you for joining us this morning. The Affordable Care Act included dozens of new requirements and enhanced authorities for CMS to combat waste, fraud, and abuse in Medicare, Medicaid, and the Children's Health Insurance Program. And now, as you know, several states are suing to have the ACA overturned, and their argument is that the law is not severable, meaning that if they're successful, the enhanced fraud-fighting capabilities of CMS would be repealed as well. So, Mr. Alexander, I wanted to ask you, if those states prevail in their argument and the ACA is overturned in its entirety, then would providers, suppliers, Medicaid managed care plans, Medicare Advantage plans, and Medicare prescription drugs plans be required to report and return any overpayment in 60 days?
Thank you very much for the question. First of all, I'd like to assure the subcommittee that the Secretary and the Administrator have made very clear that we're committed to the performing.
But if this is overturned, that requirement goes away. Isn't that true? It's a simple yes or no question.
Well, the 60-day rule is a little bit beyond the purview of what I was going to discuss today. But yes,
okay.
I believe it would have an impact. But
okay.
I would
thank you. I just also wanted to ask: would physicians be required to provide documentation on referrals to programs which contain a high risk of waste and abuse? Something else that was required under the Affordable Care Act.
We have many different sources of information on vulnerabilities in the program. That's certainly one of them.
But that would go away.
Not necessarily.
The requirement would go away. And then would CMS have the authority to impose an administrative penalty if a Medicare beneficiary or a Medicaid recipient knowingly participated in a healthcare fraud scheme?
We have multiple authorities upon which to revoke provider billing privileges or put payment suspension into place or take other administrative actions.
But the administrative penalty, that's an authority that was provided under the Affordable Care Act. And I want to highlight these because I think it's safe to say that a fair number of important fraud prevention tools would be taken out of the CMS toolbox if the ACA were overturned in its entirety. And those are just a few of them. I know there's others that would also be removed that we probably don't have time to mention right here. I also wanted, almost exactly a year ago, this subcommittee held this same hearing, and I submitted a question to the record, and I haven't received a response, so I wanted to ask it here today for you, Mr. Alexander. Certain value-based models, such as accountable care organizations, are uniquely positioned to help identify and ultimately report fraud to the Center for Program Integrity. On average, Medicare ACOs cover 17,000 lives and comprise hundreds of clinicians, and their success depends on continuously monitoring their expenditures. So ACOs have asked for a fast-track platform so they can report fraud to the agency, but it's my understanding that CMS has not done this or responded to their request. And so I wanted to ask you if you can commit to creating a platform for large value-based providers so that they can report fraud to your department.
Thank you very much. We have multiple ways to receive concerns of vulnerabilities from all of the payment structures and payment programs and payment systems that we have. Yes, we would make that available. We want to know from every source we can what are the emerging vulnerabilities so that we can place it within the vulnerability management process I've just described and address it.
We'll follow up with you on that too. Thank you.
Thank you.
And then lastly to you, Ms. Jarman, President Trump came into office saying that he was going to drain the swamp, but it didn't take long for his appointees to waste taxpayer dollars, in particular on lavish trips, on costly chartered jets. Last week, the OIG found that Secretary Price wasted $341,000 taxpayer dollars on trips that did not comply with federal policies, and the OIG recommended that HHS begin recouping these funds. I wanted to ask you, has HHS supplied you a time frame to recoup the $341,000 taxpayer dollars that were wasted?
I don't believe we have a time frame yet. The report, like you mentioned, was just issued last week, and as part of our process, we will be following up with the department on how they're implementing those recommendations, and so we will be following up with them over the next few months on how they're implementing the recommendations, and then at some point we probably will get a time frame, but we don't have one now.
Okay, thank you. I'd be interested in knowing when you have one. Thank you very much for your time. I yield back.
Okay.
Thank you. I'd like to recognize Ms. Walorski for 5 minutes.
Thank you, Madam Chairman. Mr. Begdoyan, it's my understanding that in order to implement a strategy for Medicare in line with GAO's framework, a fraud assessment must be first conducted. Can you talk about that?
Yeah, sure. An assessment is basically a bottoms-up build-out, if you will, from looking at all the, in this case, Medicare's various parts and identifying risks and that are known, and perhaps speculating on ones that are emerging. Fraud risk is not static, it's very dynamic. It shifts from region to region, state to state, city to city, as program design or counter-fraud measures take effect, those schemes evolve. So an assessment is essentially a thoughtful process from all stakeholders to determine essentially a portfolio of risks, and then also determine their likelihood and their impact. And those assessments, as I mentioned earlier, feed into a risk profile, which is the more formal documentation of an assessment.
Okay, thank you. And Mr. Alexander, Mr. Begdoyan had mentioned earlier a lot of good faith effort going on around all these systems, and I'm just curious, what steps is CMS taking to determine what order Medicare programs should develop a fraud risk assessment? And then to his point, if you could talk about the fact, is there a full timeline when each of these fraud risk assessments are going to be completed? I imagine there's a master grid by which all these things are going to be completed. So can you just talk about that of the Medicare programs, how they should develop, and then the timeline that we're looking at for all these programs?
Sure. Well, as I mentioned earlier, thank you for the question. As I mentioned, we have been and do fraud risk and risk profiling that's has been described for a long time. We, for example, have done it in the marketplace and the exchanges. We're doing it in the modeling. And with each of those steps, we're learning and bringing those learnings forward to each subsequent program. I would point out as well that each of the programs and each of the payment systems that you would do a risk assessment on has unique peculiarities to it. The way we pay for critical access hospitals is very different than the way we pay for acute care hospitals, and therefore each presents a different table or plate full of risks that need to be assessed differently and independently. So they each break into a separate brick, if you would. So if you'd imagine we're building under the framework GAO has given us a monolithic program integrity wall that would cover the whole program, it's going to be comprised of many, many different bricks, each containing within it of a risk assessment of its own. So we're in the process of doing that.
Sure.
As to the timeline, I'm not sure exactly when that all gets done, but I would assure the committee that we do these, as I mentioned, on a vulnerability by vulnerability, issue by issue basis each and every day as we see these.
Can you just ballpark it, though, just for the sake of, are we looking at 2 years, 5 years, 10 years?
I think that by the fall of next year, I think we should have a general idea of where we are. I believe that we are steadily making progress. And again, I want to reiterate that as the vulnerability process I mentioned that we're standing up comes into fruition, we will be taking each of those vulnerabilities on a daily, weekly basis, performing exactly this process, and then assessing it to make sure we're addressing it and measuring the outcome on how we're doing, moving the needle. But generally speaking, probably the fall of next year, I would think we should have something something in terms of the overall
Sure.
plan.
And back to your point, you talked about ACA. Can you talk about the ACA marketplace fraud risk assessment and how that may inform a fraud risk assessment for Medicare?
Oh, absolutely. We, of course, take marketplace exchange integrity as a top priority for us, for all of us. We are following the recommendation the GAO has given us, have performed and are performing a risk assessment specific to the exchanges. I'm happy to tell you that that very process has identified a particular vulnerability around agents and brokers. That vulnerability has led to a referral. We have also stood up a contractor, the Marketplace Program Integrity Contractor, that has the sole responsibility of working with us as part of our major case coordination process to look into that. We have referred the first of those cases. There is a criminal trial in September on that first referral, and there are more that are coming. So we are making very, very important progress there, and we expect we'll be identifying additional vulnerabilities in the near future.
Thank you, sir. And Madam Chairman, I yield back.
Thank you, Mr. Blumenauer. You're recognized for 5 minutes.
Thank you, Madam Chair. I appreciate the opportunity for us to come together dealing with these important oversight issues. One item I would just mention as a side point is that another area of potential oversight would be our committee's responsibility dealing with the integrity of the American infrastructure system. Today marks the 397th hearing that we have had as a committee in the 7.5 years that my Republican friends have been in charge. And we have had but one 5-minute witness testify about the responsibilities we have dealing with infrastructure, and that has significant impacts in terms of the health of our country, the economy, and it's sad to me that the Ways and Means Committee has shirked that responsibility. There will be a wide range of opportunities to exercise oversight in that area, and I hope at some point we own up to the responsibility we have in that regard. I appreciate the focus on the Medicare integrity. You've referenced here that we're already talking about over $700 billion in the next 10 years. If I understand it correctly, that's going to double. And so the integrity of the program is absolutely essential. Part of the problem we have in this country, where we pay more than anybody else in the world for mediocre results overall, for on average, Americans get sick more often, they take longer to get well, and they die sooner than other countries, is simply inefficiency, and waste is a part of that. I appreciate the effort here to look at comprehensive efforts moving forward. My friend Ms. Dobeni pointed out a number of the tools that were available under the Affordable Care Act, which is a comprehensive approach to dealing with America's health. And embedded in that were some elements to be able to have more efficient ways of monitoring, guaranteeing program integrity, and we have a long way to go, but there are tools there. We hope that the administration will take those seriously, unlike some of the other areas where they appear to be taking apart the Affordable Care Act bolt by bolt, destabilizing the system and making things worse. I appreciated the reference here. I believe $4.20 was returned for each dollar that was invested in terms of program integrity. Mr. Alexander, I think you mentioned one example where it was $6 for every dollar invested. I'm curious if you have some sense here of whether or not we are making adequate investment. If we have the rate of return that is 4-to-1, 5-to-1, 6-to-1, are we making the appropriate investments through the budgetary process and within the administration to be able to fully capitalize on the power of these approaches? Mr. Alexander?
Thank you for the question. First of all, I believe it's important to note that the committee and the subcommittee have been particularly good at providing resources, whether it's CARA or the Small Business Jobs Act or MACRA or any of the tools that you have provided. All of these have served the program integrity functions exceedingly well. I'm not in a position at this moment to request any particular funds. I would point out that the President's budget proposal does contain, I believe it's 17 specific program integrity-focused proposals, all of which have the capacity to advance our efforts considerably. A couple, just to mention one or two of them, we regularly see problems with what we call affiliated entities. There's a proposal that would allow revocation and denial of provider enrollment based on an affiliation with a previously sanctioned entity. As a person who was honored to participate in one of the very first healthcare fraud strike force training classes back in 2009, I believe, I'm very familiar with the fact that fraud organizations will disappear and reappear, reorganize themselves in different but clearly related corporate structures that are then untouchable. So this particular authority is one. There are several others. I would just ask the committee's attention to those.
Thank you, Mr. Alexander. And Madam Chair, I would ask unanimous consent to enter in the record a statement concerning the failure of the committee to deal with its responsibilities of American infrastructure.
Without objection, so
Thank you very much.
Thank you. Mr. Winstrup, you're recognized for 5 minutes.
Thank you, Madam Chair, and thank you all for being here today. You know, as we look at this whole process and the trends that you may be trying to find, it's kind of looking at crime stats, right? It's very, very similar. And so I'm curious, I want to ask you a little bit about the types of fraud that you see, and are we looking at breakdowns of the types of fraud? Because you've mentioned several different ways that people can go about and commit fraud, whether it's from the provider or people that pretend to be providers, et cetera. And so I'm curious as to where does most of the fraud occur? In other words, are you looking at trends like, is most of it in urban areas or is it in rural areas? Is it in certain states or in certain cities? The number of occurrences that occur and the amount of dollars that are involved with these occurrences, say per capita, and where. Do you look at trends like this? And I'm also curious to know, how does Medicare fraud compare with fraud in the private healthcare sector of insurance, if you will?
Thank you, Congressman. The answer is yes. We, in collaboration with our law enforcement partners who in the strike force are particularly adept and focused on doing exactly what you just said, we look at high concentrations of fraud geographically and high concentrations both as a monetary and fiscal matter as well. So where are the dollars going, and is that geography particularly prone for fraud or susceptible to it? And you might see that of the, I think, 9 or 10 or 11 now current strike force jurisdictions, as we call them, they're located in places where that's occurring. High volume and a particular concentration. So that's where these 75 or so very elite prosecutors, an equal number of agents from the Bureau and OIG focus their work. Our case coordination process is locked in with them once a week. We're sitting down with them, looking at the newest leads that are being brought in to assess them. And we make quick decisions as to what proper path they should be in. Is this a matter that, based on the conduct we see, should go straight into a criminal referral? Is it one that perhaps there's an administrative action we should take? Or is there more investigation necessary? Or very importantly, is it one where a provider is exhibiting a high error rate with respect to their claims, but it's apparently through error? There's no indicia of fraud, no indicia of malintent, and in that case, we want that provider not to have a burdensome, onerous referral. We want that provider to have the benefit of what we call targeted probe and educate, which is a chance to one-on-one education.
Well, I do want to go back in a second to how you compare to the private sector, but what you just brought up is key. I can remember a time, you know, I saw a patient and one of her lower extremities was a prosthetic, and I circled that one extremity is what I treated. Staffer didn't notice that, saw the lady walk out fine and billed for 2 extremities, which I noticed later, called Medicare right away and said, we're going to reimburse the $12 because it was miscoded, innocent miscoding, right? Because what I'm worried about is the headline that, you know, that there was some misdeed here, right? And that's happened to people that I know. You know, there's cases out there. I had someone who, they didn't like one code that he was using. They went into his office, raided his office in the middle of the day, led to headlines, led to a divorce, led to a tremendous amount of money in legal fees, to end up finding him $60 for one occurrence. Now, there's a difference between innocent miscoding and intentional overcoding, and I hope that you are addressing that in a more proper way. I'm going back a few years from when this happened, so it's not a recent event. But I think that's important too from the standpoint of our providers. Can we be a little more parental if someone, hey, you're not necessarily doing this right, let's correct it now, rather than raiding their office without any type of warning. But if you could, in the time I have left, talk about how you might compare to the private sector as far as fraud and abuse.
Sure. Thank you, Congressman. And of course, that process I described, I'll follow up with you about, called Targeted Probe and Educate, does exactly what you just described for a provider who needs that education. With respect to the private sector analogy, I would point out that really the goal there is to be as quick as we possibly can, not to pay and then chase, but instead to prevent a payment from going out. And I believe I hear in your question, are we as good as the private sector at doing that? I'm not sure about how they measure that, but I do know that we have several tools that we use that give us the capability of stopping payments before they go out if they're improper. For example, our fraud prevention system allows us to place edits that immediately will deny a claim if it violates a policy. We have the ability to do prior authorization. And one of the President's budget proposals that I referred to is to expand prior authorization, and I would ask that you consider that. We also have provider enrollment, payment suspension, and prepayment review, among other tools that are designed to stop those payments before they're made.
Well, if I could, and if I can indulge for just a second, I'd like to be able to get the statistics that you gather about the geographic findings that you have. I would like to be able to get those from you, and then again, also compare to private sector the amount of fraud that occurs. Is there less fraud occurring in the private sector, and why? If that's the case, I yield back.
Mr. Lewis, you are now recognized.
Well, thank you very much, Madam Chair. I want to thank each of you for being here and for your great work. I would like to ask each of you, are we doing enough as a nation and as agencies to protect our nation's seniors from Medicare fraud? If we're not doing enough, what should be our next steps?
Thank you very much, Congressman Lewis. I believe that we have resources. I tell my team all the time we have a $1.3 billion budget to protect $1 trillion in Medicare and Medicaid spending. I believe we have the financial resources to do it, although there are always emerging responsibilities that are required. But I think we have to bring greater insight to the process. And I believe that what I've described in this new coordination process is where we bring the insight of all relevant parties along what I call the enforcement continuum, which starts with education on one end and ends with criminal prosecution and sentencing, hopefully at the high end of the guidelines on the other end, and everything in between. We need to be assessing these issues holistically at the beginning together to make sure we're making insightful and proper decisions from the beginning. So I think we can definitely improve there, and we're working to do that.
I would say that there have been some progress, like Mr. Alexander mentioned, the decrease in the error rate for the Medicare, but still the numbers are so large. He mentioned, I think it went from 11% in 2016 to 9.5% in 2017, but there's still a lot of Medicare fraud out there. So I think we've made some progress, but there's still a whole lot that needs to be done, and I think some of the things that Ms. Alexander mentioned is going in the right direction. The coordination, with law enforcement and the meetings that he mentioned that they have weekly, and I think better use of the data analytics information and targeting areas where we need to use our resources. I think we need, better use of all of that, and we've made several recommendations related to the fraud prevention system that I know CMS is working on, and we just feel like more needs to be done in that area. We talked about the recoveries, but the recoveries that Mr. Alexander talked about is the identified recoveries. But what actually gets returned to the trust fund is a different amount. So the adjusted recoveries are the ones that need to be looked at to determine how effective the fraud prevention system is, and that's different from the 6.3 to 1.
Thank you, Mr. Lewis, for your question. It's a really good question to bring it all together, basically picking up on points that Mr. Alexander made and Ms. Jarman as well. There's certainly a lot going on from the GAO perspective. As I mentioned before, it just needs to be better organized and better focused on prioritized risks. We cannot fight all of them all the time, so that is very important. And then assessments will yield also additional actions that may be required. I think Mr. Alexander mentioned the President's budget request, for example, outlining, I think, 17 or so programs or activities that would certainly come into the mix. But a comprehensive, forward-looking strategy is imperative to make sure that fraud risks are identified and managed at the most effective level possible.
Are you discovering what I would like to call bad apples? The people engage in something in Georgia, then they go to Florida or to some other state and try to get away with doing the same thing?
Yes, Congressman, we are, and in only the 8 or so weeks that we have run this new coordination process with law enforcement, we are seeing emerging risks that are both geographically disparate and tied together. So we're seeing through what we call link analysis that a behavior over here that's particularly problematic is also showing itself here. And through this process we're putting together, we, along with our law enforcement partners, are linking those together. We also have a contractor that we're able to bring to bear. We call him the Supplemental Medical Review Contractor for matters that require investigative resources and have multi-jurisdictional connections. So the answer is yes, and we're working those very, very aggressively.
Thank you. Madam Chair, I would like to submit for the record a recent story from my hometown newspaper, the Atlanta Journal-Constitution. This story tells of a provider who was defrauding taxpayers and harming the elderly who was already struggling to make ends meet.
Without objection, so ordered.
Thank you, and I yield back, Madam Chair. Thank you.
Thank you. Now recognize Mr. LaHood for 5 minutes.
Thank you, Madam Chair, and I want to thank the witnesses for your testimony and your service. I understand under the fraud prevention system at CMS, there have been some steps taken to develop evaluation and monitoring mechanisms to determine return on investment and other savings when combating fraud, but that CMS is unable to evaluate all preventive activities without a comprehensive fraud assessment and strategy. Recognizing that there are a number of anti-fraud efforts happening at CMS that we've heard today, I want to focus on the Health Fraud Prevention Partnership. The Health Fraud Prevention Partnership is a voluntary public-private partnership between the federal government, states, law enforcement, health insurance plans, and others that analyzes and studies multiple payer claims data to identify providers with suspect billing patterns. I know, for example, in my home state of Illinois, the Illinois Department of Health Care and Family Services Officer of Inspector General is a member of that partnership. I think that it used in the right way, public-private partnerships are an effective tool for the federal government to harness the expertise of the private sector in helping to identify challenges like improper payments and fraud. Mr. Alexander, I wanted to know if you could elaborate a little bit more on some of the successes in fraud prevention related to the HFPP. And then secondly, maybe talk a little bit about, I mentioned earlier it's a voluntary program, how the process to join HFPP works.
Thank you very much. Of course, as you mentioned, this is a very important collaboration. It includes federal, state, and private entities. And the purposes of it is to facilitate information sharing and to identify and manage fraud risks that pervade across payers, for example, or across systems. Currently, the partnership has, I believe, 102 members. I was honored to participate in the last board meeting. Inspector General Levinson was there. Joe Beamsterbauer, the chief of the Healthcare Fraud Criminal Division, and Strikeforce chief was there as well. We were there, many of the state representatives, and we talked a great deal about how this data sharing can reveal the sorts of fraud schemes that we're looking for. For example, if the federal government is aware of a particular provider billing an excessive amount of time in a day for a particular thing. And then we're able, through de-identified data shared through the partnership, to compare that to the same provider that may have billed multiple private payers on the same day at the same rate. Then what emerges there is an impossible time scenario that is something that can be pursued. So that's a simple example of the sort of fruit that we see from the data sharing. It's a critical component in identifying risks, not just for the federal programs, but for, as you mentioned, for the state Medicaid fraud units, for the administrative programs as well, and for the private entities who are exposed for these sorts of frauds also.
What about, do you anticipate growth in the program?
Yes, I noticed that just from last year as I prepared for this, I believe the number last year for this kind of prepared answer, to the extent it might have come up again, was 79 last year. I'm pretty sure I heard 102 recently at the board meeting. So I know it's growing. I know it makes a lot of sense, and we're honored to be part of it and to actually coordinate it, and I expect additional growth.
And what about any deficiencies or challenges that you have with the program that need to be worked out?
Well, I've only had the honor of working in this capacity for 6 months. I'm not aware of any at this moment, but I would be glad to follow up and make you aware if I do become aware of any shortcomings or any needs that we have.
Thank you. And those are all my questions. Thank you, Madam Chair.
Thank you, Mr. Cabello. You're recognized for 5 minutes.
Thank you, Madam Chair, and I thank the witnesses for their time here today. South Florida, still #1 for healthcare fraud, following massive takedown across the nation. That was the headline last month in the Miami Herald following the unveiling by the Department of Justice that 600 defendants are being accused of fraudulently billing $2 billion to Medicare, TRICARE, and private insurance. It's been reported that over $300 million of those fraudulent claims by South Floridians were treatment for opioids, home health, and prescription drugs. Madam Chairman, I'd like to submit into the record the reference Miami Herald article published in June regarding healthcare fraud in South Florida.
So ordered.
Last year in a hearing before this subcommittee, I asked why we are always chasing so much fraud. We learned that one of the biggest challenges is understanding the cause behind improper payments, since it isn't always fraud, but also clerical and technical errors that contribute to improper payment statistics. While I'm grateful for the work to bring bad actors to justice, as evidenced by the most recent takedown, we still need to do more to cut down on pay and chase methods and focus on prevention measures. I agree with Deputy Inspector General Jarman that a comprehensive program integrity strategy that focuses on prevention, detection, and enforcement helps address the sources of improper payments. I worked on a bill with my colleagues, Representatives Thompson and Fitzpatrick, to introduce the Reach Out Act, which recently passed the House. This bill would direct CMS to work with certain entities, including quality improvement organizations, to engage in educational outreach with prescribers to prevent prescription drug abuse. This bill is specifically directed toward educating outlier opioid prescribers to help change their behavior and prevent overprescribing. Mr. Alexander, and by the way, this issue is in many ways personal to me because it's no secret that South Florida is the Medicare fraud capital of the United States, and my constituents no longer want for that to be the case. So my question to you is, how does the administration view prescriber education as fitting into an overall anti-fraud strategy?
Thank you for the question. As you know, first of all, the Secretary and the Administrator and the President have made it absolutely clear that fighting the opioid crisis is a top priority for the administration, and we're working very closely with law enforcement to do that. We're bringing a number of tools to that fight, specific tools from the program integrity perspective. They would include the MEDIC, the Medicare Drug Integrity Contractor, which provides investigative work and referrals for fraud and other problematic behaviors in that space. And the MEDIC is part of the UPIC, MEDIC, MPIC major case coordination process I've described. So once every 7 weeks and more frequently if needed, the MEDIC is in the Center for Program Integrity reporting in real time on its current investigation, and we're making sure they get where they need to go. We also have projects like the TRIO project, where we're monitoring the prescribing of this particularly deadly trio of substances that are very, very dangerous for beneficiaries. We have comparative billing reports that we provide, that are generated and that are provided to help us with this. We also will be standing up what's called the preclusion list, which is going to, place certain problematic prescribers on the list and require the programs to deny payment for claims associated with those particular prescribers. And finally, the new lock-in authority that we have, thanks to the Congress, we now have the authority to limit high-risk beneficiaries to specific pharmacies and specific prescribers. All very, very important tools that we're bringing to that important work.
Well, thank you, Mr. Alexander. I appreciate CMS's commitment, and I'm very grateful to the chair, to the ranking member, because this is all very demoralizing to American taxpayers, and obviously it's unfair to Medicare beneficiaries. Every dollar that goes into one of these fraudulent schemes is $1 less that we have for those who have earned Medicare by working hard in our country. And again, in South Florida, it's particularly personal and painful. Our community does not want to be known as a place where Medicare fraud is prevalent, and we look forward to working with you, with all of you, to root out this horrible situation in our country. Thank you.
Thank you, and I want to thank our witnesses for appearing before us today. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. And with that, the subcommittee stands adjourned.